So the changes in physical therapy then in the 1990s were manual therapy increasing in popularity. Exercise began to be included as part of manual therapy, but it was very general and not specific. The McKenzie, mechanical diagnosis and treatment, also became very popular as a treatment, with some research showing its effectiveness in some conditions. But motor control was also gaining recognition as a factor in musculoskeletal disorders, mostly by the work of the Australians, Paul Hodges and Gwen Jowl primarily. And then there were other treatments like myofascial release and nerve tension interventions. The big question to me was, how do you know what to use when? And how do you choose from this array of different types of treatment techniques? In the United States, the educational level was changed in these years, and it was taken to the clinical doctorate level. So now students got their baccalaureate degree and then had 3 years of postgraduate education. The reason was the profession thought we would be having more direct access. In other words, patients coming without a doctor's referral, and that we needed to be able to differentiate conditions that belong to the doctor from conditions that just belong to the physical therapist. So we indicated we were using a diagnostic process and clinical reasoning, but we never had our own diagnosis. These were just ones to sort out diagnosis of conditions that didn't belong to us. The other thing that we didn't do in the 1990s was to consider and address the progressive nature of musculoskeletal conditions. In other words, that they aren't an acute problem, but they begin early and progress for many years. So in some ways, what we were trying to do, because we saw all these options out there, was to reduce the silo of focusing on just muscles or just joints or just the nervous system, and put it together in one big movement system. And recognizing also that biomechanics are a critical determinant of how muscles function, of how the nervous system functions, and that it's the everyday movement patterns that become so important. And it's so important for the patient to be an active participant and not just a passive one. And just to emphasize, so we try to kind of redo terminology to make it more inclusive. Rather than talking about strengthening muscles, we talked about muscle performance, trying to consider all the aspects of how muscles function, whether they're the right length, whether they're the right strength, whether they are activated, and whether they're stiff or not stiff. Skeletal, looking at all of the motions, but during active performance, not just in a passive way. And how the nervous system recruits patterns, rather than just isolating a muscle to see if it's recruited, and appreciating motor learning, how you establish patterns. So that we were trying to put the whole system together rather than looking at just individual components. So this is a graphic of depicting the movement system. And as you would anticipate, it includes the musculoskeletal system and producer of movement, the nervous system as a regulator of movement, pulmonary, endocrine, and cardiovascular systems that support those other systems, but that are also affected by movement. Their health is affected by movement. And then you wrap it all up in the integumentary system. So this is one way of depicting the movement system. So in 2013, the American Physical Therapy Association identified the movement system as our identity. It represents our body of knowledge and expertise. And I think it emphasizes what we know rather than what we do. And it's a great system to be in charge of because it's essential at all levels of the organism. Even synaptic transmitter moving, our insulin going into membranes, not just how you move your limbs and not just how you move in your environment. And then the definition of the movement system adopted in 2019 by the American Physical Therapy Association is the integration of body systems that generate and maintain movement at all levels of bodily function. And this is the American Physical Therapy Association graphic. And I just like to point out that a number of systems can impact movement. And very popular is the biopsychosocial model. Well, bio pertains to all systems involved in the movement system, and you can't have psychosocial without the nervous system. The same thing's true with pain. There's no pain if you don't have a nervous system. So all of these aspects that have described physical therapy are relevant to the movement system. And of course, the best way to optimize the function of all these systems is movement or exercise. And that's where people should think of us as having expertise. What's our current understanding of musculoskeletal conditions in particular? That they're chronic, they're related to lifestyle, begin early and progress slowly. There's a lot of work for us to do because in America, 50 to 75% of Americans have a musculoskeletal pain condition. We know that recurrence is very common, and we know that attempts to treat the symptoms can often result in addiction to opioids. And that began to happen in the 1990s, where they made pain the fifth vital sign. And they told physicians that people won't become addicted if the pain is real. Total misunderstanding. Okay. We do know that pain is a major problem, and that as most people know, that there's bigger understanding of pain science, which has led to approaches like cognitive behavioral therapy. I think the big questions are, what % of patients are affected in this way? And as best I can get it out of the literature, it's 15 to 20%. And I strongly believe that if we had more effective approaches to helping people with the cause of the pain, not so many would develop this uncontrolled fear of pain. Okay, so, and there are also a variety of approaches to trying to classify patients, particularly those with lumbar or low back pain. And some are by the pain characteristics. What we've been trying to do is look at the response to movement. And because we're trying to assess with research as well as clinical practice if movement can induce pathology. And that's some of the work that we're trying to do now. And there's been much research already by Linda Van Dillen to look at this. So I think if we're with the movement system and we're exercise experts, we need to consider the musculoskeletal system, the nervous system, cardiovascular, pulmonary, and endocrine system, because those are the bioenergetics. And we've got to look at all of these features, not just at one isolated component. So this is a diagram to emphasize how important it is to make movement system diagnosis when movement is impaired, not optimal, excessive, or insufficient. And it can induce a kinesiopathologic problem, which means how movement is inducing the pathology, or a pathokinesiologic problem, how a lesion, a pathology in one of the contributing systems causes bad movement, and they can go back and forth. And then these are just some ideas of different diagnostic classifications. And just a graph to show you how many musculoskeletal pain exists in at least over 50% of the people. This is just a data to show you that. And lower back is the worst, and then knee follows that. So 1 in 2 Americans have a musculoskeletal condition, and that's comparable to all the people with chronic lung or heart conditions, and it costs $213 billion a year for treatment, care, and lost wages. So this is the kinesiopathologic model, a theoretical model of how we believe things might work. This is the model that we're investigating. And we have our contributing systems. It's the everyday movements, repeated movements, and sustained alignments. And how your personal characteristics, how much you do, affects the kind of adaptations. It results in a path of least resistance. A joint begins to move too readily. It becomes unstable and leads to one of the syndromes. And the details of how this model works are part of our continuing education courses, books, and publications, and they'll be addressed at another time. I just want to give you a few examples of movements that become slightly impaired and that can cause pain. And in many ways, it's like setting up the balance of the wheels and the alignment on your car. If those wheels aren't aligned properly, they wear the tires out funny. You can get thicker tires, but you haven't fixed the problem. So the idea is to optimize the alignment so that the body or the tires last a long time. So this young woman has knee pain and she's going up, taking a step up, and this doesn't look too bad, but if you compare it to this, where now she's aligned the femur over the tibia, if she steps up this way, she doesn't get her knee pain. So that slight change makes all the difference to what's happening in her knee joint. We know also there are there are studies that show 4 degrees more hip medial rotation demonstrated by going down a step can cause not only knee pain, but it's also associated with hip pain. So 4 degrees can make all the difference in whether you have hip or knee pain. This young woman also, she's a runner that had knee pain. And if you watch her standing on one leg, you can see that the right leg, where the knee pain is, behaves differently than the left leg. She gets medial rotation and hyperextension. With a little instruction to contract the hip lateral rotators and prevent the medial rotation and hyperextension, she doesn't have knee pain. Now, this can't go on just when she's standing on one leg, but it also has to carry over to when she walks, when she goes up and down from a chair, and all of her daily activities. And you can tell by the pronation of her right ankle that this isn't just something that happened with this demonstration, but is a prevailing part of the pattern that she uses. And this is an Olympic level marathonist who had right knee pain, and you can see how much more varus she has on the right than she has on the left. The hypertrophy of her biceps femoris tendon and the extreme medial rotation of her femur at the knee. And even when she's sitting, you can see the posterior lateral displacement of her right tibia with respect to the femur that isn't present on the left. And when she stands on one leg, there's an increase in the medial rotation and varus of her knee that can be corrected by just having her contract her gluteal muscles. She had previously been treated by 8 ultrasound treatments to her knee, which didn't help her knee pain at all, while this one simple intervention enabled her to resume her running career and compete for a team on the Olympic marathon team. And again, just to stress, this is what she has to do, not just standing on one leg, but when she was walking, and she also did it when she was running. And she knew that if she got her knee pain back, she just wasn't tightening her buttock enough to control the rotation. She also couldn't sleep on her left side with her right leg draped across her body because it stretched out all of her lateral rotator muscles. It's so important to address all of the everyday activities that play into the problem and teach the patient how to correct them. And this was a figure skater also with knee pain, and it was her left knee, and you can see with this arrow how the knee is headed medially over her tibia. And again, you see the severe medial rotation of her left knee and the difference in the valgus of the left knee versus the right knee.
You mean varus?
Yeah, we'll call it varus.
Okay. Okay.
And she too has greater pronation of her left ankle than her right ankle. or the knee,
右の
as the knee is going medial. Mhm. And then this is her skating position, and you can see how the femur is going medial of her foot, even affecting her big toe. And this would be the corrected alignment. And just to make the point, when she's going up a step, she uses the same strategy, which again has to be corrected during all of her activities. Okay, and then this older woman getting up and down out of a chair, putting her knees together and pushing with her hands keeps her lower extremities weak rather than doing it where she has to use her muscles. The prevailing issues are still that practice is still based on treatment systems. We aren't really recognized as movement or exercise experts. In our country, there's a reduced amount of payment for physical therapy services. We still have great variability in practice that makes it difficult to demonstrate our effectiveness or to reduce costs. And then we have a problem that the term physical therapy is used as though it applies to any form of physical treatment, which would be like saying, take a pill without saying what pill it is. This is what I propose is that the best answers to these prevailing issues, what I'm hoping ideas that you will think about and maybe share with me, are promote our knowledge of a body system, the movement system. Clarify that movement is the cause of pain and that it can be corrected. That we've got to clarify that neurological conditions can also be classified to know what the best treatment strategy is and to what the prognosis should be. And that we really need to use movement system diagnostic labels defining kinesiopathologic problems, the movements that cause pain, as well as pathokinesiologic problems that develop particularly in people that have neurological disorders. So diagnosis is a really big thing, and we need to use system-specific labels. That's the story. Please help.
Thank you, Shirley.
All right.
Woo,
Woo.
good stuff.